Do spend the next 30 minutes of your life watching this video, and trust me, you're not going to regret it. Today we will be speaking about how to test for language disorders. But before we get to that, we have to address a more important question. Since when did we start testing language disorders? I'm sure most of us have gone through the extensive neurological examination pro forma required to do a complete neurological examination. But most of us do not remember actually seeing a part called language disorder examination. So let's see where this particular examination actually comes. So this is the neurological examination pro forma that is commonly followed. It starts off with mental status and higher mental function examination, cranial nerve examination, motor system, sensory system, reflexes examination, coordination and gait examination, and ends with autonomic and peripheral nervous system examination. Now, the very first part of the neurological examination, the mental status and higher mental function examination, is a big gray area and a question mark for most of us. In fact, from the time I've started doing my neurological examinations in MBBS, I have just been documenting patient is conscious, oriented, cooperative, higher mental functions, normal. Today, we will try to take baby steps into understanding this particular part of the neurological examination by learning about language evaluation. So what exactly is this mental status and higher mental function examination? So under this particular part of the neurological examination, there are multiple domains which are tested. Now you can see it starts off with evaluation of level of consciousness, followed by physical appearance, emotional status evaluation, attention, language, memory, constructional ability, and higher cognitive function examination. So this is an extensive list of examination in itself, and this is why we really can't blame anyone for completely ignoring its existence. So this is the part of the examination that I will be speaking about today, that is language examination. But before we go on to these later domains of higher mental status examination, we have to understand that it is important that we always document these first three. Why is it so? So the level of consciousness in a patient. Now imagine you have a patient who is a little drowsy and who's an altered sensorium. You cannot really go and ask him to repeat your sentences and understand what you're trying to tell him and actually expect him to respond in a normal way. The level of consciousness is the first domain that you have to be testing, and only if the patient is alert can you go ahead and administer tests to check all of these other domains. The next thing is emotional status, physical appearance. Now imagine there is a very angry patient who's agitated, in a fit of rage, has come with a stick in hand. You cannot really make him sit down and test his memory function. It is a little impossible to do that. So we also have to document a patient's emotional status and physical appearance and administer these tests only if their emotional status is stable. The next thing is attention. Now even if a patient is alert and he is in a normal emotional status, if there is a lack of attention, if his attention span is reduced, then he won't be able to actually engage in the test that you are giving him. So it is important that the patient's attention span also be normal before you can test the following domains. So let us presume that we have with us a patient who's alert, who is in a normal emotional status, and he's attentive. We can then proceed on to testing language function. So what exactly is language function testing? I know this is beginning to look like a maze inside a maze, but yes. So when you're testing a patient for language disorders, there are multiple areas of language that you are going to be testing. This includes spontaneous speech, comprehension, verbal fluency, repetition, naming and word finding, reading and writing. All of these are the different aspects of language that you test. But before going on to testing any of these aspects, there are certain prerequisites that have to be met. And only then can you go ahead and test for language. What are these prerequisites? It is important that the patient's visual pathway and auditory pathway and sensory pathways, all of these sensory pathways should be normal. He should be able to see, he should be able to hear, and he should be able to feel. Now, why is this important? It is because let's imagine there is a deaf patient sitting with us and we've asked him, sir, where have you come from? Since he is hearing impaired, he hears my question wrong and answers with a different answer. In that case, I cannot say this patient, oh, this patient is not comprehending my question, he has Wernicke's aphasia. So it is important that we absolutely ensure that their sensory pathways are functioning fine before we test for language. The second prerequisite is that even his motor pathway should be absolutely fine. Cortex, the muscles involved in producing speech and the nerve supply to these muscles, all of this should be absolutely fine before we can go ahead and test for language function. Alright, so now let us presume we have a patient who has come to us and his sensory and motor pathways are functioning just fine. And now we can go ahead and test his language function. So we start off with the first aspect of language testing, which is spontaneous speech. So how do we test for spontaneous speech? So we test this by asking patients open-ended questions like, tell me about your day. What did you do from the time you woke up? So when the patient comprehends these questions, they go back and try to pick out these memories and they frame it into sentences and come out with their complete formed sentences. So we can actually kind of test spontaneous speech only if they speak in sentences. You cannot ask them yes or no questions. Always open-ended questions to test for spontaneous speech. So what exactly happens when you ask a patient, tell me about your day? So this is what happens. We were assuming that our patient's auditory pathway was functioning fine. So he heard my question and it got transmitted to his auditory cortex, and then it went through his association cortex and reached the vernix area. Now the vernix area has comprehended my question, made sense of what I want to hear, and then it has sent the output to the Broca's area. Now Broca's area, apart from receiving input from vernix area, also receives some input from premotor cortex and from all our memory areas, and it comes out and makes these fully formed sentences, which is then sent over to the motor cortex and the patient speaks out the sentences. Okay, so by asking a patient about his day alone, we are testing his sensory pathway, his vernix area, his arcuate tract, his Broca's area, and the motor pathways. So we are pretty much testing the entire speech pathway by asking the patient simply to speak about his day. Now we should be addressing a very obvious question at this point. If we have already tested the vernix area, arcuate tract, Broca's area, and all other speech pathways just by asking about a patient's day, then why do we have to proceed with all of those other tests that were written in my language maze? Why is all that necessary? We have already finished testing the entire pathway. Now there is a reason why we do the further tests. Now if you have seen a relay race, okay, in a relay race there are 4 athletes, okay, let's call them A, B, C and D. Now A starts the race, passes the baton to B, then B passes it to C, C passes it to D, and then D finishes the race. So in this particular race, we evaluate the entire team as a whole. So we see which team is the strongest. It is possible that A is a little slow and D is extra fast and is making up for the slowness of A. Do you understand? So in a relay race, we test the entire team and we cannot actually bring out the small weaknesses present in each of these athletes. Similarly, by asking a patient to speak spontaneously, we are testing the entire speech pathway and not the individual components. So we will not know if there is any subtle deficit involving one particular area. So it is important that we test each of these subcomponents in isolation after we have done this gross examination of the speech pathway. So after finishing spontaneous speech, we will know only if there are some very gross deficits and not subtle deficits involving each of these areas. So after we've asked the patient to speak about his day, what do we observe for? We see if spontaneous speech is present at all in the first place. There are some people who have severe aphasia and are not able to talk at all. And if they are talking, we look for any obvious dysarthria or dysprosody. So what is dysarthria? What is dysprosody? So if there is abnormality in the articulation of speech, so whenever we speak, like I've already explained in my previous video, there's an understanding part of the speech and expression part of the speech. So the expressive speech, that is Broca's area, motor cortex, and then all the distal pathways, if they are involved, there is impairment in the articulation or production of speech, and if that is present, it's called dysarthria. So what is dysprosody then? When I'm speaking right now, there is a certain melody to my voice. I'm not speaking in a very monotonous way like a robot. Okay, so if I start speaking like a robot without any melody in my speech, then it is said to be dysprosody. Dysprosody again means that there is some issue with the expressive pathway. Alright. Then if there is any word finding pause, which is usually seen in conductive aphasia, as I've already explained in the previous video, and if there's any paraphasia or new words. We will just be speaking a little about paraphasia and new words soon. So presence of paraphasia or new word formation implies involvement of the vernix area or sensory aphasia. So these are what we are observing for in spontaneous speech. Now at the end of our examination for spontaneous speech, we finally say whether the patient has fluent speech or non-fluent speech. We look for paraphasias. So now coming to paraphasia. Now a patient is said to be demonstrating paraphasia if he is substituting the normal words that are used in a sentence in that particular context with other words which are not expected to be used over there. And depending on the kind of words that he is substituting, he is said to have two different types of paraphasias. What do I mean? The first thing is verbal or semantic paraphasia, wherein he drops the entire word which is supposed to be used and uses an unrelated different word. For instance, I drove home in my pen. Now, pen is absolutely not right for this particular context. It's just some other random word. But this word exists in dictionary. This is a word that is very much present in dictionary, but it is not right in this context. So when he's using words like this, then it is called verbal or semantic paraphasia. A phonemic or literal paraphasia is when a patient uses a similar sounding word. I drove home in my lar. Now this doesn't make sense, and this particular word as such just sounds similar to car. Okay, so this is called phonemic or literal paraphasias. Now these are the two types of paraphasias. Now apart from paraphasias, a patient can also use neologism, wherein he is substituting the word with a completely made up new terminology. For instance, I drove home in my strub. This doesn't make sense at all. So he's made up this new word, and in that case it's called neologism. So these are the different things that we look for when we are testing spontaneous speech, and we have to make special note of presence of paraphasias and neologisms because these imply involvement of the vernix area, the sensory aphasia. Alright, now once we have finished with spontaneous speech evaluation, we move on to the next part of language examination, that is comprehension. So to test comprehension, what we do is, there are two tests that can be administered. The first one is pointing commands. So you sit in front of the patient and ask them. For instance, I have my patient sitting in front of me and I ask him to point to the fan, point to the window, point to the pen. So, so you start off with one object at a time first, and then slowly you start increasing the complexity. How? Like I can say, point to the fan and then the book. Point to the color green and then the cupboard. So similarly, you go on increase the complexity of pointing commands, and it has been noted that a normal patient is able to point to 4 or more objects in sequence. So if he's able to point to 4 or more objects in sequence, you can say that his comprehension seems to be doing fine. The next test you can do is yes or no questions. You can ask him, is it raining outside? Is it Wednesday today? Is it morning? So you ask yes or no questions, and at least 7 questions have to be asked in sequence, and the patient has to answer all of these 7 questions right before you can actually say that his comprehension is working well. Some patients just keep answering yes, 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 yes for everything. When their comprehension is impaired, they just keep making a pattern like yes, no, yes, no, yes, no, or yes, 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 yes. So in that case, you have to rule out that this is not happening, and you should ask 7 different questions and ensure that he has answered all the 7 questions right. At least 7 questions have to be answered right before you can declare that his comprehension is working fine. Now, an important thing that you have to note in these 2 tests is that the patient doesn't speak out in it. When you're asking him to point, he's doing a motor sequence. He's going to point with his finger. When you're asking yes or no questions, he's going to nod or he's going to say no. He's not going to speak out. He's not going to say yes. He's not going to say no. And he's not going to speak during this particular test. So why is it that we are doing this? Okay, now let's presume that I've asked my patient to point to the floor. Alright. So he hears my question, and then this information is going to his vernix area and he's going to comprehend this question. Now once he has comprehended this question, what he has to do is point to the floor, which is a motor activity. So he will be bypassing the Broca's area completely, and this information is going to go directly to the motor cortex and he will point. So this is why we ask patients those questions which is not going to involve production of speech, because we want to test only the vernix area in this question. We don't want to test for Broca's area, because that will again be a relay sort of thing. So we've asked our patient if his comprehension is fine, he will understand our question and he is going to point. So if there's any subtle deficits in comprehension, this will come out during this particular test. That is why we are going to ask our patient only to either point or nod to imply his answer and not by speaking out. So this is how comprehension is tested. Alright. Next, coming to verbal fluency. Now once we've finished comprehension and we have decided that yes, my patient's comprehension is fine, then we move on to verbal fluency. So when we are testing a patient's verbal fluency, okay, there are multiple facets that we check. We are evaluating his ability to actually scan memory, find the right words and produce the series of words in an appropriate manner. So he should actually look for the answers in his memory, and he has to put it together in a beautiful sentence and actually be able to put it out. That is what is required for verbal fluency. Okay, we're basically testing the Broca's area when we test for verbal fluency, and these are the tests that we do for verbal fluency. First thing is the animal naming test. Alright, so what is this animal naming test? So we seat our patient, we time him for 60 seconds and we ask him to name all the animals that he knows over that 60-second period. So the animals which are on the land, on water, whatever it is, you have to ask the patient to name whatever he can think of. Now a normal patient can actually name between 18 to 20 animals within a 60-second period. Now this of course depends on the age of the patient, but usually anyone 69 years of age or lower are able to come with at least 18 to 22 animals in this 60-second period. The next test that is done to test for verbal fluency is the FAST test. Actually, you can administer either of them. Now, the FAST test is conducted by asking the patient to name all the words that he knows, which begins with F, A and S. So each of these letters is timed for 60 seconds. You give 60 seconds for each of these letters and ask them to start naming all the words that they can think of. So again, depending on the age, if the patient is 79 years or younger, it has been seen that the normal number of words that they produce it ranges between 36 to 60. If they come within this range, it is considered to be normal. So what exactly are we testing in this particular test? So let's say I've asked my patient to name all the animals within the 60-second period that he can think of. So he will comprehend the question and then he will make sense of it and all of that and transfer this command to our Broca's area. Broca's area will scan memory. It will get all of these different animal names that it can think of, and then it is going to put it together and send commands to the motor cortex. So we have also already tested the comprehension of the patient. We know it's functioning fine. So now in this test, we're only testing whether the Broca's area is able to retrieve all of these names from memory and is able to produce all of these words in sequence over a 60-second period. So mainly fluency is for testing the activity of the Broca's area. Next, moving to repetition. So when we test for repetition in our patient, like I've explained in the previous video, the part 1 on aphasia, we are testing for the activity of the arcuate tract. In this case, we ask our patient to repeat words after us and we make a list well in advance. We have this written down in our paper so that we don't have to keep searching around for sentences, words and sentences to repeat. So this is the list which is given in a standard textbook, Stubb and Black's, and in this case, as you can see, there is increasing complexity of these sentences with increasing number of syllables. So we ask them to repeat after us and we slowly increase the complexity. Now normally a patient can repeat until 19 syllables. So he's able to repeat after us. Now if he is not able to repeat, you can consider that his arcuate tract is affected. So let's see how exactly this is testing the arcuate tract. So we've already tested for our Wernicke's area function with comprehension. We've tested for Broca's area function with verbal fluency. Now let's say that I ask this patient to repeat ball. Alright, so he hears this and there is not much of comprehension to do really. Wernicke's area is not being tested in repetition because he basically hears it and he just has to repeat it. He's not comprehending, not making sense of it or anything. It is then transmitted through the arcuate tract and he is again not retrieving memory, not doing much work. He's basically just receiving this command and then he is going to send it over to our motor tract. So since we have already established that our vernix area and Broca's area is functioning fine after testing comprehension and fluency, now we will effectively be just testing on whether our arcuate tract is functioning well by asking our patient to repeat the sentences with increasing complexity. So this is what our repetition test entails. Next, moving on to naming and word finding. After testing for vernix area, arcuate tract and Broca's area, we would expect that that is the end of language testing, but no. There is this other part of language examination for naming and word finding. Now, the ability to name objects, to find words, to identify objects that you know, it starts off quite early in life and it persists relatively well preserved till quite late in life. So, young children are able to name objects, extremely elderly are also able to name objects. This is one of the earliest acquired language skills. Now, what is the area of the brain which is responsible for our ability to name things and to find words to describe objects? There are multiple papers which have described various areas, and most of them say that the area is in the anterior temporal lobes, and some other papers say it is in the posterior temporal lobe near the angular gyrus. Now, there's still a lot of research that is required to pinpoint the area responsible for naming and word finding, but we will just be discussing right now about how to test this particular function. So we test naming and word finding by the confrontation naming test, wherein we sit in front of the patient and show him different objects and ask him to name it. Alright, so we have to do anywhere between 10 to 20 items, and these items should be belonging to different groups, and they should include low frequency and high frequency items. What do I mean by low frequency and high frequency items? Now, some items that we use are those objects which are commonly used in our life, and people are actually able to name them easily. Now, there are other items which are not very frequently used, low frequency items. So these the patients find a little difficulty in naming. For instance, this is the list of objects which has been given in Stubborn Black, and this, as you can see, colors of course are all high frequency items. We usually see all of these different colors. Clothing and room objects. Now, door, watch, shoe, shirt, ceiling, all of these are also relatively high frequency items. Body parts are also eye, leg, teeth, thumb, knuckles, all of these can also be named. But these objects, if you can see, like watch stem, coat label, watch crystal, all of these are objects that we don't usually use. So the patient should be should be shown all of these different objects and asked to name them, and that is how you test for naming and word finding. It has been seen that out of the total of 20, patients are usually able to name at least 18 of them when they are normal. So this is naming and word finding test. And finally, what we have is reading and writing, which are also components of language function. So starting off with reading, when you're testing the patient's reading ability, you have to test both his reading comprehension and his reading aloud ability. Meaning to say, you should be testing whether he is able to understand what he has read, and also whether he is able to replicate this understanding by reading it out aloud. So both has to be tested. Now, reading out aloud can be tested by asking him to read from a book, like words, phrases, sentences, and paragraphs. So this is increasing complexity. So first you ask him to read words, then phrases, then sentences, then paragraphs. Then reading comprehension is tested by asking him questions. So you write these questions and ask him to answer by nodding, like a yes or a no. So by doing this, you will be testing whether he is comprehending these questions which is written in a paper. So how exactly does the reading pathway work? Alright, now let's say I have written a sentence, did you watch a movie today? And I've sent my written question to the patient. Now he sees the question and this visual information reaches both of his occipital lobes into the visual cortex. So we do know that, for instance, the left cortex will be looking at the right hemifields. I'm sure that is something we all know. So the visual information reaches both of his occipital lobes. Then what happens is, from the left side, if the patient is left hemisphere dominant, this information is processed and it is sent over to the vernix area. The non-dominant hemisphere information crosses over in the posterior corpus callosum, that is the splenium of the corpus callosum, and it is then going on towards the vernix area. So both of this information is eventually going to be transmitted to the vernix area itself. Now, if I'm testing his reading comprehension, he will just get all of this visual information in his vernix area, he will comprehend it, and the output will be sent over to his motor cortex, and he will nod, saying yes or no by nodding. So in this case, we will not be testing his Broca's simultaneously, we're just testing his reading comprehension. When I ask him to read out loud, he will see this, he will comprehend it, and then again Broca's area is involved and he will read it out loud. So both of these components have to be tested when we are testing for reading function. Next, moving on to writing function. So when a patient's ability to write is impaired, he may be producing language error, spelling error, or paragraphia, wherein he is using words, he's writing down words which are not normally used in that particular context. So to test his writing ability, we ask him to write letters and numbers and names of common objects. So we ask him to write all of these, and with increasing complexity, of course, we also ask him to write short sentences. So this is how we test his writing ability. Now again, the exact center which is involved or which is responsible for writing ability is not really known, but it has been pointed to be the angular gyrus, which is present at the lower end of the parietal lobe, somewhere over here. Now the angular gyrus is said to be the part of the brain responsible for writing ability. So what exactly happens in case of writing also is that he will comprehend the question, the information is taken over to the angular gyrus, which then processes it and sends out the command to the motor cortex, which is responsible for producing all of these written symbols. So this is important for us to understand. Now there are multiple clinical scenarios I'm sure many of us might have heard, like alexia without agraphia, agraphia without alexia, and Gerstmann syndrome and all of that. So to understand that is very simple now that we know the language pathways. So if you can see over here, now let's say that the patient has a posterior circulation infarct. So basically the posterior circulation supplies the occipital lobe, it also supplies the splenia. So let's say his left-sided posterior circulation infarct is present. Alright, so in this case his left occipital lobe cortex is gone, so it won't receive visual information. Along with that, it is also involving the splenium of the corpus callosum. So this entire area gets infarcted. So in which case, the ipsilateral visual information is not reaching the vernix area. The contralateral information is received by the right occipital lobe, but it can't go over because the corpus callosum is disconnected over here. So in this case, the patient will not be able to read. Since his vernix area and his writing, all the areas involved in writing that is present anteriorly are preserved, he will have alexia without agraphia. Alright, so seen in left-sided posterior circulation stroke, alexia without agraphia. Now the other thing we have to know is about agraphia without alexia. I don't know how many of you have heard about Gerstmann syndrome, which usually occurs when the dominant parietal lobe, dominant inferior parietal lobe is involved. What happens when the dominant parietal lobe is involved is that the angular gyrus gets involved. Alright, in this case, since the angular gyrus is considered the center of writing, the patient is able to comprehend but he cannot write because his angular gyrus is involved. His vernix is paired, he can understand, he can comprehend, but he's not able to write. His visual pathways, however, the visual cortex to the vernix area and then all the way to the Broca's area, this is functioning fine, so he doesn't have alexia. He has agraphia without alexia, seen in Gerstmann syndrome involving the dominant parietal lobe. So this is about alexia and agraphia and testing for reading and writing. So to summarize our language examination, we start off with spontaneous speech by asking a patient open-ended questions. Describe your day, what have you been doing since morning, either of these open-ended questions. We then proceed to comprehension with pointing commands or with yes-no questions. Once that is tested, we go to verbal fluency with the animal naming test or the FAST test. Then we ask the patient to repeat our sentences in increasing order of complexity. Then we go to naming and word finding with the confrontation test. We sit in front of them and ask them to name the objects which belong to different categories, mind you, 4 different categories, high frequency and low frequency objects, and we ask them to name them. And finally, we end it with asking the patient to read and nod and also to read out aloud, and obviously by writing as well, which is writing sentences, words, numbers in increasing complexity. So this is how we test for language function. Again, I hope this was useful. Do let me know if there are any doubts. Thank you.